A warm hello to all of our viewers joining us today. Welcome to this month's live social media event with the Sugar Queens. We want you to stay with us for the next 30 minutes because not only will we be discussing the whole enchilada plus guacamole connected systems. And you know what? You guys are in for a treat. We have a guest, Prince, joining us. So, hello, I'm Dr. Eden Miller. I am a family physician, a diabetologist, an obesity medicine specialist. I'm from Bend, Oregon, and y'all know Jen. Jen, introduce yourself.
Hi, Jennifer Goldman, and I am a professor at Mass College of Pharmacy. I run and direct the cardiometabolic services in a primary care practice. I've been practicing for 35 years, and I'm thrilled to be here again with my queens and our special guest.
Mm-hmm. I'm Davida Kruger. I'm a certified nurse practitioner in Detroit, Michigan, Henry Ford Health System. I've been in this role for the last 42 years. And if we're queens, why isn't Rich a king instead of a prince?
I know. It's kind of a hierarchy. I'm sure we would bequeath him the king. And with that, Rich, please introduce yourself.
Greetings, everyone. I'm Rich Bergenstal. I'm the executive director of the International Diabetes Center in Minneapolis, Minnesota, which is part of Health Partners. And today I'm honored to join this royalty of diabetes management expertise. So.
Well, I'm so excited. Way to cap off. This is our 12th episode, and who better than to have the king, Dr. Richard Bergenstal. So let's get right to it. Today, we're going to talk connected systems, but what does that mean? What are we talking about when we say connected systems? So our viewers out there, what experience have you guys had with diabetes devices, technology? It comes in all sorts of shapes and sizes. So as we're presenting, let us know in the chat where you're at. Some of you might say connected devices, connected systems. What is that? Others are well versed in it. And please send us any questions. It's so imperative for this to be so meaningful to you. And we want to make sure that we cover all those bases. So I'm going to start with Davida. So I want you to think top of line, your thoughts. What are diabetes devices and how are they connected?
Well, what's interesting is that, because of what I do in life, I only think of connected devices as being insulin pumps to CGM. And I have to step back and realize that there are a lot of devices based on the needs of people. So we're talking about blood glucose meters. We're talking about connected insulin pens. We're talking about CGM to pens, to pumps, to anything else, or meters to, apps on your phone. So I think that we have to realize that all of that are devices that have enhanced the way we practice and, of course, the lives of people with diabetes.
Oh, so well put. And Jen, from the pharmacy perspective, give us a little deeper about how these connective devices allow us to get data and those kind of meaningful metrics.
Yeah, so when we're talking about connected systems, we're really referring to this ecosystem of devices that communicate with each other. So CGM, smart pens, pumps, all really designed to simplify care for people with diabetes. So, as a pharmacist, I really feel that these systems empower patients. So they give us rich, real-time data. So that helps with timely medication adjustments. So from a medication optimization standpoint, connected systems close a lot of those gaps between what we prescribe and what patients actually experience.
Well, that's great. Rich, will you take a little bit about how the ADA and the standards care are really trying to get us to embrace this kind of connected technology?
Yeah, I think the ADA is doing a great job on their, what I call their Chapter 6 and Chapter 7. Every January, I look and see, what's new? What just happened in standards of care? And we keep watching the recommendations to say CGM, oh, it's good for MDI. Oh, it's actually good for basal insulin. And now 2025, you should consider this for people not on insulin. So it just keeps evolving thanks to the work of all of you and and others out there to do the trials, to get the data, to put it in. So it's a process of evolution. We need data, we need to put it in the standards of care, and then we need to put it into practice.
For sure.
So I just want to comment, because Rich just brought up a great point on the standards of care, and everybody out there might not be as familiar. It's our Bible that comes out sometime at the end of the year, beginning of the year, and it goes through every medication, every device, what's type 1, how to diagnose, anything you can imagine. And there's an abbreviated form if you're in private care and you don't want as much as we do. And the chapter 6 and the chapter 7 is where our technology is. But you can Google that or go to the American Diabetes Association's website and get yourself a copy, or you can get it on the app. And it really is the Bible. It is the Bible we all live by, and the experts are the ones who develop that. And it really is important to have.
So Jen, do us a favor real quick before we dive into kind of the meat of this. I want you to talk about some of the nomenclature. Time and range. What does that mean? Targets, GMI, glucose variability. As you know, many of us may know that our king here, he helped define some of those. But tell us a little bit about that before we dive into some of those connected devices, and we'll have Rich talk about that.
Yeah, for sure. Especially if the king is involved in this.
Right.
Maybe we should defer to him.
Embarrassing him.
We covered this in an earlier episode, so if you need more detail, go back and take a look at the earlier archived episodes. But time and range is that goal that we're looking for patients to be in that range, and so we want them to be in range at least 70% of the time or better, depending. Remember, the ADA standards of care. We're looking at individualizing care for patients. So it's not a one size fit all. It's kind of in general, if you want an A1C of less than 7. And remember, the time and range we want not to be variable. So we can have an A1C of less than 7 and people are all over the place. So we want them to be in that range and not so variable. So that GMI is kind of like an average. So it's not the end all be all. I don't
I call it the sensor derived A1C.
So, I mean, similarly, you can have a GMI that looks good even when you're variable. So that's almost like a tool, a screen, but to be in range is what we're looking for. And we can adjust those ranges for patients, so pregnancy or people who are, we want tighter control. Even we want that time and range to be a little bit less if we have someone that's older and at risk of falls and has had hypoglycemia. So, but in general, 70% for the majority if you're looking at that A1C goal of less than 7.
Well, that's great. Rich, do me a favor here as we talk about those prescribers, those that are looking at those patients, trying to give them their customized technology connected devices. Like, how do you introduce that to patients and families? How do you decide who's a candidate? Or do you think everybody has that opportunity, at least in some way?
Well, yeah, I mean, I think people have diabetes need to know their glucose. And it's just crazy. I mean, I was so glad that SMBG was discovered and invented, and I just can't wait for it to go away. So that we can, move everybody on to CGM where you know your glucose, but you know your picture, you know your profile, you know your trends. You can see what you're doing well and where you need some work. And so yeah, everybody needs to be introduced to it, and sometimes they get the lingo, time and range and time below, and sometimes they need the simple words like more green, less red. Let's get more in range, and let's make your profile flat, narrow, and in range. It's a process. It's an evolution.
Can I just make one more comment? The ADA didn't just come up with, hey, we want to do this because we like it and it's nice. I mean, it's based on data, right? So we know we have improved patient outcomes with CGM. So that CGM use improves time and range, which leads to less hypoglycemia, less DKA, better outcomes, less hospitalizations, less ER visits. So an improved patient engagement. So patients do better adherence, better efficacy.
That absolutely. And the other thing is that while we're talking about getting people into time and range with A1Cs less than 7%, I've been around long enough to know that unless I had CGM, I would not be pushing half of my patient population to an A1C less than 7 because I would be concerned about the risks of hypoglycemia. But now it's not like you say, oh, well, that patient is, I'm going to pick a number of 72, that they can't have an A1C of less than 7%. But yes, they can if I put a CGM on them, because I'm not as concerned about hypoglycemia.
So Rich, you mentioned about getting those people connected with their data. So walk us through a little bit. And I, for many of our listeners who have been with us for quite a while, this might seem basic, but there really is a shared decision making here. We have the person with diabetes, we have the HCP, and kind of talk to this slide about how there's a benefit to the wearer and there's also a benefit to the prescriber.
Yeah, no, thanks. I keep studying that ADA algorithm, and I keep saying we need to figure out how to use CGM. We need to figure out how to use the drugs. We need to get people engaged, the healthcare professional engaged. And it just sort of hit me like, well, this is like a little grid, a little 2x2. We need strategies and we need good educational tools for people with diabetes, but we need them for the healthcare professional also. We need to be experts in our devices, but we also need to know how to use the drugs. So you put them together and all of a sudden you can start to get your clinic or your head around how to get these to work. So let's just take the picture and say, person with diabetes, they can look at their screen, they can see minute by minute what they're doing, what this food does, what that food does, what exercise does. And that's great. Just give them a CGM and their A1C will go down 0.3, 0.4, 0.5. But that's not enough. Teach the health professional, teach those listening how to look at it with them, and you get another 0.4, 0.5. So you need both of those together. And then on the drug side, yes, we're going to teach you side effects and don't miss your dose and get the timing right. But the healthcare professional has to help figure out, well, which medications and personalize it. So anyway, you put all those together, and I think in the middle comes that shared decision making. And that's how I've just tried to think about it. And what I love about shared decision making is it kind of means we have to listen for a minute, right?
Yeah, for sure.
Sometimes it's not all talking. It's like, well, what do you need? What's right for you? So anyway, that's how I put it together.
Any additional comments, Jen and Davida, before we dive into those connected AID systems?
Yeah, the only comment I would make is I agree with Rich 100%. Shared decision making is where it's at, because if I say, oh, we're going to get you to a goal of less than 7%, and I want you to look at 70 to 180, whatever it is, if the person with diabetes, I don't go home with them at night, and you guys know that I think that's a really good thing. But I think that ultimately the decision, it's my job to know all this stuff, to put it out in front of people, and then let them pick what works in their life, best for their life and best for their outcome, and let me use the data too to help guide them to where their goals are. But it has to be shared decision. It can't be top down. It has to be shared decision.
For sure. You need to involve the patients and the caregivers right from the beginning. So help them understand what their options are and how those devices can fit into their lives.
Yeah, matching the technology to the person. With that, Davida, take us through this next slide that talks about those connected devices. You have been keeping this up to date, right? And so kind of walk us through some of those. This is hot off the press, by the way.
Yeah, this is really good.
You were just bragging about some of the research you've just started today. So I'm going to tee this up to you.
Thank you so much. It is my baby, and I have everybody cut it out and put it over their desk. And every time I make a change, I send it out again, because it is difficult, in even of those of us working in the field. And we want individuals who have that are wearing these devices to have choices. So if a patient chooses the iLet by Beta Bionics, they can use either a Dexcom G6, G7, or Libre 3 Plus. The InPen SmartFriend would be Simplera. The 780 insulin pump would be Guardian 4. Omnipod 5 insulin pump can use a G6 or G7 or a Libre 2 Plus. The t:slim X2 insulin pump, G6, G7, or Libre 2 Plus. The Mobi AID is G6 and G7, and then the Twist, which is the newest to the market, actually hasn't quite bridged the market, but just made the announcement that they'll be using Libre 3 Plus. And I think having it in front of you, because it's easy to order the wrong thing. And
Right.
today, when I was trying to get a 2 Plus from one of our DMEs, he said, "Don't you mean 3 Plus?" I said, "No. I mean 2 Plus, and I need you to send me a 2 Plus."
Yeah.
So,
So screenshot this. This is a
Yeah.
good resource. Screenshot this.
Yep.
Yeah.
And so, and yes, and when it becomes famous, I'm not even charging you. So screenshot it now. No, every time there's a change, I update this and then I pass it around our group again, because when you're writing prescriptions, and sometimes too, someone will say to me, this patient's not connected and I don't know why. And if I can go in and look at their prescriptions, I could say, well, you got this pump and this sensor, they're not going to be connected. This is what you need to do.
Exactly. And, let's look at the next kind of thing about data and connectivity. And I just want to say, as we're going to our next slide, that our sweet listener, who is always here every month, said we also get to share data with caregivers. And sweet Chris is on the line telling us that we need to remember our caregivers. And that's what is great about it. So many people can benefit through this. So Jen, tell us a little bit about how that data provides those individuals who are on the care team, the CGM, the smart pens, the AID, tell us, how is that data connectivity working?
So it certainly does point out how collaboration is very important. And I think that having all that data, it's really transformative. It helps us kind of review all that. We can do this virtually, which is very, very important. You don't have to be in person. You don't have to be, have that patient in front of you. But having these devices virtually, so CGM and the smart pens and the AID devices, it allows us to make therapy decisions very quickly. You don't need to have an office visit necessarily. And, as a pharmacist, being able to pull this data into the EHR, and I'm sure just, all clinicians being able to kind of pull this information and make those therapeutic decisions. So that these reports that we can access allows us to find hypoglycemia, find hyperglycemia early and immediately and in real time, and help patients understand why, so that we can make those decisions. So that in that early tech integration leads to fewer emergencies and better patient outcomes.
For sure. And, Rich, speak just kind of briefly, not every single device is actually being connected to the HCP. There's still a lot of room for improvement, right? You mentioned you put a Libre on, you put a CGM on somebody and you get the data, but now that we have all these connected things, is there a lot more work to be done about getting these reports to those HCPs?
Yeah, no, I think there's so much potential, and we've started, so that's great. But we got to keep moving. We got to be sure the reports are more standardized, so you learn it once and you know how to look at it. When you see a CGM, you kind of get it. When you see a pen report, you kind of get it because it's in the same lingo. And you see an AID report, so you see kind of an AGP type version. And then don't give up on trying to get this CGM into your electronic record. It's hard. It's really hard, but we got to get there eventually, because we want all that data integrated. And so keep up looking at their phone, look at the cloud, but get ready for that data to be right in your electronic record.
Hey, Davida, we had a great question just come up, and we have a listener who wants to know if there are any CGMs linked to food diary apps and such. And so to speak to that just briefly.
Yes, there are. I can't remember the names of them, but yes, there are. Happy Bob is one of them that I'm thinking about. Happy Bob. And then there was a couple other that I just saw a presentation at the international meetings. And yes, there are. You'd have to Google them because I can't remember the names of all of them, but you can. There's something integrated with everything. The other thing is a lot of these devices have their own food apps.
Correct. Yeah.
Like the pumps have foods that you like the best or use the most often, and it'll tell you the carbs or how much insulin you normally take for that. So a lot of the pumps now have within their arena and the CGMs as well.
Even the apps to forward viewing the CGM, they have a lot of that as well. Well, speaking of the international meeting, Davida and I were as well as Rich, were fresh off of Amsterdam, but Rich did quite an amazing presentation at ATTD, Diabetes Congress last week in Amsterdam. And can you explain a little bit to our viewers how you think we should rethink the current type 2 diabetes algorithm?
Yeah, I mean, I was saying how much I appreciate the ADA and EASD and putting together this algorithm. And over on the right side of the algorithm, it says, you want to get weight management and glycemic management optimized. And they give you which drug you should use and which is the highest priority and how do you work through it. And it's really a good report. But I just got distressed when I got to the bottom of that. And I was looking at it again and again. And here's how it ends. It ends with, if you spent the last 6 months, a year adjusting your medications and you're not at goal, your A1C is too high, here's what you need to do. And first of all, I said A1C. I said, why don't they ever say if your time in range is too high?
Yes.
I mean, why does everything have to be A1C based? Okay, so that was one that distressed me. The second was, if you spent this year or two and you're not at goal with your weight or your glucose, why don't you think about some diabetes education or consider CGM?
2 years?
And I said, wait a minute. Let's just look at the next picture. These are the two areas that come after the fact. Let's redo the algorithm and look at this picture on the right side now. One more there, and just say, why don't we just move these up front? You see a patient, you want to get the weight, you want to get the glucose in control, get them to diabetes education, start a CGM, use CGM to guide your management. And I think you're going to get to your goal a lot better than spending 2 years in the dark and then saying, well, maybe I need some help. So that was my suggestion. Just reverse it a little and we'll do a lot better.
But saying initiate CGM is exactly what has to happen.
Yeah.
We cannot tiptoe around consider CGM. We have to initiate it, and everyone deserves a CGM.
Right. And earlier, not later, not after the fact.
Well, it's a identification tool for lifestyle and stress and medication adherence. It's like, why would you not have it at the foundation? Because all of those other things are so intimately tied to that. Not only that, I don't know about some of our listeners, and they can put that in the chat, but many of my DSMES and CDCESs, they are actively engaging with those CGMs. Heck, if we gave them license, they'd be prescribing them everywhere, right? Which is awesome. I think it's amazing. I say more power to it, but I don't have that vote. But I would agree with you. I love how you're reorganizing this. You're bringing this like, wait a minute, we've got this backwards. We can't, I heard a patient of mine said once when we had put a CGM on them, they says, Dr. Miller, it's very hard to manage what you don't monitor. Right. And when you're not monitoring things, how can you manage it? So
can I point something out that has come up before? You don't need to be a specialist to recommend CGM. And, we keep hearing this where I've had patients that their primary care said, oh, you need to see the endocrinologist. No, we have disciplinary teams and interdisciplinary providers here, and anyone should be, and everyone, not just anyone, everyone should be involved in what is the value of a CGM, where does it fit, what is it, and you can have it. You can all have it. Everyone is entitled. Queen Davida, what is it that you say? My favorite thing on earth?
CGM is a right, not a privilege. Everyone deserves CGM.
Exactly. And we all need to get involved in doing that. And it's not just for a specialist. We need to leverage our interdisciplinary communication here.
Yes. And we also talk about what we call benefit and approval. And yeah, we've talked about the standards of care. You know, we believe any person that's on any kind of injectable insulin, I don't care what flavor of diabetes you have, you're going to be on it. But one would also say if you have chronic kidney disease or cardiovascular disease or other medications that can cause hypoglycemia. And, you know, to your point, you know, we just started some research in using CGM as a risk identification, risk reduction tool for early diabetes. Because I think, Rich, what you were saying is that why do we want to adjust the algorithm? Because early intervention is critical. And then continuing of monitoring, whether you're prescribing lifestyle or medications, or whether you're doing other types of interventions, such as connective technology. And really at the end of this is personal, right? You know, this is not herd diabetes. This is diabetes on the individual and personal level. So, you know, we're getting to our end very close here, as we always do. And, you know, we have, you know, some few parting thoughts for sure. We've covered a lot, and we want to make sure that you can catch all of our other series. This is our 12th, Queens, and we have so many other series that are still there, still archived. You can still get that, you know, continuing education credit for sure. We want you to do that. The Queens aren't going anywhere. So for sure, stay tuned, because we have some upcoming next season Queen type of things. And you know what? Our listeners, you know what? Put in the chat. What do you want us to talk about, right? We're open to suggestions, you know, because we want this to be meaningful to you. And so with just the last few moments that we've had, you know, kind of summarize, Davida and Jen, what it's been like for this, you know, 12 months of bringing you the Sweet Talk with the Sugar Queens.
Jen, you want to start?
I've loved it, and I keep thinking of new things, and people reach out to me, and I text the Queens, this happened to a patient, or a friend did this, and they're not giving her CGM and she's pregnant, and all kinds of things. We need to talk about this. We need to talk about this. We need to talk about this. And so that's been wonderful. And, you know, one point about what King Rich just said, the algorithm, the suggestion that you make is treat to success versus treat to failure. So allowing them to fail, and now let's try the CGM, but using that CGM first is that treat to success. So there's tons of things for us to talk about.
I'm always amazed at how quickly the 30 minutes go. And I also, when I look back over the year and I look at every topic that we have covered and how much we have engaged, and because we're on the cutting edge, like we come back from a meeting and we share things about what went on in the meeting. Rich presented this, we heard that. I just think that it's always realistic and cutting edge and very timely for the people that are listening to us. And I know it's not just healthcare providers out there listening to us. We know we have a group of patients that are following us as well. And it's always funny because, you know, you do go to the meetings and it's amazing how many people will say to you, I'm following the Queens. I see you guys.
Yes.
So, but I think that we have touched a lot of people in a lot of really good ways with a lot of really good information. And I know in the next season, we'll continue to do that. But I agree, if people have topics they want us to cover, let us know. That would be awesome.
Well, with that, Davida, one of our listeners just said, what about an episode on the caregiver perspective of what do we look for? How much do you talk to them? How do you engage with that? I think it's a good idea. I don't know that
Yeah.
Well,
We can talk about how the devices follow the patient, how you make choices to do it, how you pick the right person. That would be awesome.
That would be great. Well, it's been an absolute pleasure. And Rich, thank you for joining us, being the king of time and range and all those many things that have helped us. It was an honor to have you as our very first guest. And we want to thank you for participating in this activity. We really enjoyed spending time with you.
My pleasure.
Until next time.
Thank you. Thank you for having me.
Bye. Thank you, Rich. Good to see everybody.